Mansi, Mansi, hello, Mansi, are you there? Mansi, hello. Hello, hello.
Hello, good evening.
Hello. Hello, Lakshmi.
Yes, sir. Hello, sir. How are you?
I am fine, thank you. How are you?
Very good, sir. Very good. Thank you.
I was not aware that this was there. This was a nice session by Sita and all of you.
Yes, sir. Yes. Actually, I didn't know that I was in the panel till yesterday, actually. So
Oh
they
God.
indicated me, like usually we take part in this session. Like I'm part of this organizing committee for this, but I wasn't particularly aware about this panel today. So that's why I requested today about the change. Sorry for that.
No, that is fine, but we could have asked the students to, listen to her lecture. It's nice lecture, isn't it?
Yeah, yeah,
Comorbidities with epilepsy, correct?
yes.
With the PD.
Especially pediatric epilepsy, yes.
Yeah, it's a very nice lecture. I think we could have had our session next Tuesday, innit? So these sessions are happening every Tuesday or they
Yes,
are
sir.
periodic?
Yes, sir. This is today is the 13th of the series. It has been happening every Tuesday, 8
Very
to
nice.
9:30. 8 to 9:30 is the time. Unfortunately, it is almost similar time to yours also. Yeah. So people have to choose between. It's unfortunate, I would say.
I know, so it's the 13th one, correct? Yeah. I know this thing we started, I think, somewhere in the end of May.
Yes,
These
sir.
this
Yes, sir.
program for
I agree.
PGs.
I agree. You have been doing for many months. I agree.
I know.
Can we check my
I'll just call Mansi, our
slide?
coordinator. She was there actually. Just hold on. So she can start our videos, I think. I don't know whether we are able to start our videos now.
Um, no.
We are able to now.
How
Great.
come I'm not able to start my video?
You are not able to?
Yes, sir.
Okay. Just hold on whether I have the. You try and start. You are not able to start your video.
No, sir. Not yet.
Okay.
Host has stopped it, it says.
Okay. So I will request her. Just hold on. So these are nice sessions, really. The problem that has been we Pramod has also joined it. She is good lady on the call. I think she'll call.
In our session, like the questions, audience questions, we will take at the end of my talk, or
No, I think let us. Okay, so yeah, you will have to.
yeah, maybe if there are one or two questions, we can complete it then and there. Because my talk will be short. I will take 12 minutes or so, not more than that.
How many minutes?
12, 10 to 12.
Oh, you will finish that fast?
Yeah, the slides are slow. Like you gave me 15 minutes, right?
Yes, yes.
So 12 minutes should be fine for me.
Oh, that's very good. I mean, the whole presentation looks very much, full and all, but that's really good. I mean, if you manage to do it in 12 minutes, that's very nice. Yeah, I think what we'll do is we will take your questions at the end of your lecture itself.
Yes, sir. Maybe because the other session is there.
How much? Okay. ओके काही प्रॉब्लेम आत्ता काय सगळ्यांना व्हिडिओ ह्या दोघं झालेत तिघातले त्यांना व्हिडिओ हे करायला लागेल ना व्हिडिओ ऑन तेव्हा ते हो हो येस शुअर 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 नो प्रॉब्लेम येस ओके या
Hello, Shripad sir.
हॅलो गुड इव्हनिंग
Good evening, sir. So, hello, Dr. Lakshminarayan.
Hello, sir. Hello, Dr. Pramod. How are you?
Hello. Did you check your slides?
we're just
Not yet.
about to the lady has just called.
Okay.
She will give us some instructions and she will switch on the video thing, which share the screen.
I think I'll be able to share, sir. Can I?
Then share it.
Yeah, I
Then
think.
share it. She's come on now. She's come on in, so you can share your screen and yeah, great. Lakshmi, your presentation looks very much full, but then if you are able to finish it that fast, let us see. I will learn from you how to manage each slide. That's good. Yeah, yours is being displayed very well. No problems.
Thank you, sir. I'll then.
Great, great. Pramod, I think you can check yours as well.
Yeah, I'll check mine.
Sure.
Okay.
I'll request in 2-3 minutes. I'll request
Now we have the video, sir.
Yeah, we have Dr.
Jay also.
Will. Okay, I'm also.
Lakshmi has.
Okay, so let me share my slide.
Yes. Lakshmi, you just speak a little louder than the way we are speaking. That will convey slightly.
Is it okay now?
Yeah.
Check 1, 2, 3.
Yeah. That much is enough. That much is enough.
Fine. Thank you.
Okay, 1 minute.
Yeah. Lakshmi has that this thing as well, the Epilepsy Academy. He's a busy man.
Okay.
It has already started, correct? Who's now doing the thing along with you? Lakshmi? It's begun at 8?
It's basically Dr. K. Radhakrishnan and JMK Murthy and Dr. Rathore. These are the three people that are organizers, main organizers.
Chaturbuj.
Yes.
Nice. Good. You're able to?
I'm just, yes, sir, 1 minute.
Yeah, yours is an online thing. No?
I can't see my Google. Just seeing where it is. The Google slide page, I'm just seeing why it's not going. Screen. This is. Just see, maybe I'll just close some windows.
Last few months we've had to learn a few things about technique.
Yes, sir.
I still feel a bit. I mean, Sudhir Kothari is a very nice. He's techno savvy. Ah, yes, good.
Okay, it's now visible, no, sir?
Yes.
And I will say play with present with Slido. Sorry, I should have clicked present from the beginning. Okay, let me just see.
Yes. It's okay.
I have 30 questions, sir. I'll cut short if it's going over time.
Yeah. What we'll do is you can you after say 22, 23 questions, a feel as to how things are going.
Yes.
Whether the students are feeling tired, and then you can stop at an appropriate time, and then we will end the session, and we'll take a bit of questions from the students.
Okay.
So it's going to be Ajay and yourself only to answer the questions. Lakshmi is going to later on. We will let a few questions if at all there are for Lakshmi's presentation. He's going to present first, then Ajay.
Okay. Oh, he won't be staying for the entire program, Dr. Lakshmi, no?
Yes, sir. I have a panel discussion at 9 p.m.
Okay, right. All right. Sure.
I will just leave after 8:50 or 8:55, something like that. Sorry for that. I didn't expect that to be there.
Just call.
No problem. No problem. Sir, this Slido polling,
Yes.
students have to open the Slido app on their phone, is it?
Yeah, either they download and open the Slido app. If they have not downloaded the Slido app, then they can open Google Chrome on their mobile phone, and just put slido.com, and the window appears wherein they key in the
Four digits.
code, and then they write their name. And once they do that, they get connected to your presentation, where
Okay.
questions start getting displayed on their screen.
Okay.
Pay attention to their mobile as well as a laptop screen.
So this instruction, when do we give? Before the quiz or before at the start of the program itself? These instructions?
Yes, I think no. Now personally I feel majority of the students have become well versed with, because we've already conducted quite a few quizzes with
Okay.
dimension and other things. But even then, no, we are not giving instructions at the beginning, because first we have these two standard lectures.
Okay.
As you take over the session, at the beginning you give a couple of instructions. The same thing that I said just now, that we are going to have a quiz with Slido, as majority of you are aware. For those who are not aware, kindly open the Slido app or a window slido.com in your mobile, so that you are able to vote. And once you opened it, key in the 4-digit code, this, whatever, the 29, whatever you have, and enter your name, and you will be able to vote the answer to your question.
So
just give them a few seconds and then begin.
Okay. I was just thinking whether they will have enough time to do all that before I start the questions.
Yeah, so I think pause for 15-20 seconds. It takes no more than that. But
Okay.
in my understanding, majority of them
Already have it.
already know that we are doing these quizzes in Slido. Most of the PGs and even a few consultants who log in.
All right.
Hello. Kyle. Arey baapre, what is that thing? I don't know. So is it possible for me to unmute you? Arey baapre. Correct. पण तुझं स्वतःचं. It's okay. मी आहेच तिथं. I will run the thing. तसं काही टेन्शन घेऊ नकोस. आता फक्त काय, you just stay around, आणि काय असेल तर I will call you on mobile. मग आता काय करणार आता यार? Absolutely, absolutely. Yes, yes. Okay, yeah. Ajay, you'll have to you'll have to unmute your
Yes, sir.
unmute it.
Am I audible, sir?
Yes, Ajay.
Yeah.
Can
Hi,
we check?
hi, Ajay.
Let us check your presentation as well. Lakshmi and Pramod have.
Yeah.
No problem. The lady who conducts the whole session, for some reason she's not able to unmute herself. Although this Manasi dikh raha hai na aapko? She's not able to unmute herself. So I will be around. If you have any problems, I'll call her. If we have any problems, we'll call her. It should be. I don't know what this Zoom does at times. Now she's unmuting us, but not able to unmute herself, being the host. I don't know what. This is beyond my comprehension. This technicalities of it.
I'll just try to share my screen, sir.
Yes, yes. Share it.
You're able to see that. You're able to see my screen.
Yes, yes.
Yes, yes.
Okay, it's changing also, no, sir?
Yes.
Yes, we are able to see you. Great.
Sure, sir.
Very nice. Very nice. Good. Now what has happened to the videos? So, for the time being, the epilepsy video EG and all, you've begun again, all of you. Because in our institute, for 3-4 months, it was sort of on the hold.
We have started, sir. We have started again, but but we do COVID testing for all long-term monitoring patients.
Absolutely.
But you started.
Absolutely.
Same here, sir. We have also started.
For a couple of months, the video AG monitoring unit ward was also allotted to the COVID patients. Those 5-7 beds because we were falling short of beds, but now I think that state is over. Every third, fourth week, we were doing COVID duties.
Mm.
One of my duties, I suffered, and since then they have not allotted me as yet. Let us see now. Sujit has been doing more duties than all of us.
Yes, sir.
Sujit has had to do, I think, he may have done 4 or 5 by now. 5 duties, each lasting 1 week.
1 week, huh? Oh.
7 days constant. You are the COVID consultant for one whole ward, which is around 35 patients. Not very pleasant, really, I have to say.
Yes. Yes.
And somehow there is a lot of expectation more than what is available to give for COVID. As such, है ना?
Yes, sir.
That is another, I have to say, a little bit of, sometimes you feel, what can I say, pressurized by the community.
Yes, sir.
They bring their patients to big hospital and there is that, hey, that now everything will be okay type.
Okay, yes. Are your numbers dropping, sir? COVID?
Dropping, yes, certainly. We have 2 buildings, each has a take of 400. The old building was completely, the epilepsy unit was in the old building, is in the old building. And the whole old building was converted to COVID. So the cataract daycare unit and all those, those things had to be given of the pediatric, because we didn't have many pediatric admissions. They were all given away to the COVID patients. Now I think the numbers have got reduced, but that has taken in another problem brought on. We were not finding patients for non-COVID.
Not, yes.
Otherwise, the system are used to using all those beds. So we refused most of the semi and semi-urgent admissions.
Yes, sir. Our video EG and PSG and pulmonology sleep study are all now combined in one area. They were all because they wanted more and more beds for COVID.
COVID, same.
Put all of us, lumped us all in one section now.
Yeah, that is, I call that collateral damage, Collateral damage, and many patients did not, our neurology patients did not follow up properly.
Yes, sir.
Their own problems, epilepsies and other. Somehow, at least Maharashtra government has not managed it well. I don't know about others. Has not been able to manage well. राहुल ते मंगळवारचं करतोय मी. तो मी नंतर लावू का? हां, मी नंतर लावतो तो. Yes. So a bit of, I don't know about the states. Karnataka, is it managed well?
No, sir. We have very high number of cases, Bangalore especially, and the usual problem with coordination, finding beds, patients being turned from hospitals, all those issues. And the government wants private to take care of all the patients.
Absolutely.
Rates offered are very low, and the mandatory bed has to be allowed, and so many issues.
No, they started in Pune. They started a big. They erected a big unit in our government engineering college ground. We have a very around 600 this thing, and then somehow they were not able to run it properly. And it closed down and they were again reopened. So all kind of chaos. The thing for so lot more interest in epilepsy, correct? Now epilepsy as a subspecialty, isn't it? I'm seeing
Yes, sir.
a lot of them.
Therapeutics good, surgical interventions are improving, imaging and localization is improving.
Absolutely.
Genetic studies are now more available, so we are able to identify most of the cases now.
Absolutely. I mean, our epilepsy surgery unit is relatively new. I think around 3 years.
Mm.
Good job.
Yeah, Sujit is very active, so we keep hearing from him. Sujit is
Yes, yes.
about this.
Doing quite well. We were not sure. See, for Pune, Mumbai being close by, there was a slight degree of uncertainty whether patients want to go to Mumbai rather than get it done. Sangeeta Rawat has a big name there,
Mm.
and even there are others as well. So then, yeah, it did pick up. There was a bit of apprehension to dedicate. It requires a bit of money and space and all that, but then
Yes, sir.
we're quite glad about that. But it requires a lot of convincing,
Lot of talking, and
lot of talking.
it exhausts you a lot because you need to really work on one patient for a long time.
Absolutely, absolutely,
Educating them about the plan of treatment, everything is time consuming.
absolutely, absolutely. Has she opened the thing for? I think let us please know how many because this guy. That's good in a way. We- हा चालू करू हे म्हणजे ते attendees. Yes, yes, so that we can see. I don't know what's problem with her. Are you guys using Zoom for other things, Lakshmi, or you have other interface? Zoom.
Yes, we are using Zoom now. We used to use the other one that didn't work well. Has a very good interface for, especially for videos. The other platforms are not that good for videos. So
For Windows.
now we are going to Zoom entirely.
So, hello. Well, Shipra, can I call you in an hour? I am conducting a seminar. Unless it is urgent. Is it very urgent? Okay, I'll call you back. I'll call you back. Yeah. So this epilepsy academy, basically you guys devised it and the Abbott is doing the logistics, Lakshmi?
Yes, sir. About was initially they were to provide the platform. So they had the other one. What's that name? They had the other platform. I think they had spent some money on that platform, but the videos did not work with that. So we had to go with our own Zoom finally. So they organize the logistics and the invitation and those kind of things. But scientific part is ours.
So they are only partially involved in the sort of management.
Yes, sir. Mainly, we thought it is for the platform. Finally, their platform didn't work. So, like, we didn't have to have them finally. Retrospectively thinking, like,
You could
we
have
are
just
using anyway.
run it all by your own. It's okay. It's fine.
This is that Nissan meeting, right? Today, Dr. Sita Jayalakshmi's.
Yes, sir. Yes, sir.
Yeah, they were doing on Cisco WebEx. It didn't work out.
Yeah, WebEx. That's a very cumbersome. Even to join, that takes some 10-15 minutes sometimes.
Yes.
WebEx doesn't work that. Too much of, I think it is very secure, but we don't need secure for this scientific meeting. We don't need that much security. We are not
Yeah, we
discussing
got
some
to let
financial
people
details.
join, correct? Correct.
Yeah, it has some multiple layers of security that affects the functionality.
Absolutely. The DNB students, all of you have DNB or DM? What is it? The DNB have not yet joined, I suppose.
Not joined. So the counseling is postponed, I think.
Oh, is it postponed? Okay.
Yes, there is some case that is coming from Tamil Nadu and Kerala, some regarding some in-service PG quota, some quota. So 8
Then
to
in service for DNB as well.
or maybe DM, because the counseling is together, no?
Yes, yes, it is.
So 8th October was supposed to be the counseling date, and now that's postponed till further order. So we don't know when.
These poor people, their term will be counted 6 months from the day they join, or they will be given that discount of for their first term, because then they will lose a few months, correct? They will end up losing months.
Yes, sir. Yes, sir.
Now that the whole results are out, they should just get over with it. But I suppose when it's case, then stagger along. Horrible, yeah. Somebody, when will we get? What does it want to ask? Okay. I think we'll wait until around 35-40 people are there. Since this batch DNB exam has got over, I think some of the attendees are now relaxing, many, which is good for them. August we had this last thing, last weekend. The OSCE also was a bit new for, it was new for me. Have you been through OSCE before?
No, sir. No.
It was new for me, but we didn't have to do much during the exam really. There wasn't much we had to do. Most of the things were from the center itself. I suppose it will be the same for the December session.
Probably, sir, because the COVID situation
Remains,
so I think it will be the same pattern.
it will be the same pattern. It's easy for us in a way. We have to arrange patients and other things.
And students also remain in their same, they are not required to travel now. Otherwise, they might end up in some different place.
Some different places, yeah. That was the thing. So in a way, it's good for them. But I think couple of them, for my center, they did travel from somewhere, Hyderabad or somewhere.
Oh, okay.
Yes, they had to. Because they had to juggle a bit. There was one from Bombay, I think.
You had a Bombay candidate coming to Pune, sir?
I think so. We had one Bombay, and there was one or two from South as well, yes.
Okay.
To us. One external examiner they got from Mumbai as well. Rest they tried to manage locally. I think let us begin because Lakshmi also has to start. So I think yeah. Good evening, everybody. As you all know, we have been running the epilepsy modules. We've finished with two of them, and you heard many lectures, one from Krishnan earlier. Today, we are going to have two shorter lectures to begin with, as we do, and then it will be followed by a quiz on all the lectures or topics that we have covered. So without any further delay, we will begin with our first lecture. There has been a switch in the sequence, and Dr. Lakshmi Narayan is going to deliver the first lecture. And his lecture, as you know, is on a drug. There is one that we've kept on medicine to make you realize the importance of learning all anti-epileptics. And this one obviously is on Perampanel, which is one of the most recent ones. So I hand over the session to Dr. Lakshmi Narayan and ask him to begin his lecture on this drug, one of the most important drugs.
Very good evening, everyone.
Yeah, you will have to share screen again. Yeah, Lakshmi. Yeah.
Now, can you see, sir? Yeah.
Yeah. Slightly louder. If you can be slightly louder.
Yeah. So, very good evening, everyone. First of all, I would like to thank Dr. Pujari and all the organizers of the fine meeting for inviting me to be here today. It will be always my pleasure to share with the PGs and the neurologists my experience on the newer anti-epileptic medications. Today, we are going to talk about one of the most important newer addition to our anti-seizure medication armamentarium, that is called Perampanel. So why it is so important? So as you know, this is a famous slide from the landmark papers of Martin Brody and Patrick Wan. This they are comparing two of their papers, one from 2000, the other from 2012. But most surprisingly, we know the facts that the first anti-epileptic medication causes seizure freedom in about half of the patients. The second, combination of first and second, almost 2/3 of patients. But over the years, even with the addition of anti-epileptic newer medications, this figures have not changed. From 2000 to 2012, the remaining 1/3 nearly of patients who are drug resistant remain the same even after addition of so many anti-epileptic medication. That is a bit unfortunate. That's a bit frustrating for all of us. But that is mainly because most of these cases are surgically remediable or genetically driven. Those are inherently so drug resistant. So most of you would have seen this slide, a variation of this, where we talk about the different anti-epileptic medications with the year of their marketing first. So today we are going to talk about one of the newest anti-epileptic medication, that is Perampanel, that has been marketed since 2012. After that, we have had another one, that is Brivaracetam, Briviact, that came into market in 2016. So this is a slide again most of you are aware of, the different mechanism of action of various anti-seizure medications. Here I would like to point out the three novel mechanism of actions, including sodium channel blockers. In that we have a lacosamide, that is one of the newer anti-epileptic medication that has a novel mechanism of action compared to the conventional sodium channel blockers. In that it accelerates the slow sodium channel deactivation rather than the fast component. That is the novel mechanism of action. The other medication, levetiracetam, brivaracetam, works through synaptic vesicle protein, SV2A. That is another novel mechanism. And we have the third medication, what is called Perampanel, that works through AMPA receptor in the postsynaptic membrane. So if you take glutamate, all of us know glutamate is one of the most common excitatory neurotransmitter in the brain, and it acts through two neurotransmitter receptors, AMPA receptor and NMDA receptor. So AMPA receptor is the main receptor for rapid effects of glutamate. So this is one of the most important component for excitatory postsynaptic potential, whereas NMDA works very slow, so it does not contribute that much to the EPSP. So if you come to the AMPA receptor structure, it has a glutamate binding site on top of that in the membrane surface, and there is a transmembrane non-competitive binding site. In the once the glutamate binds its corresponding receptor, the channel opens and it allows influx of sodium, at times calcium, into the neuron. So this is the open state of the channel. Without the glutamate binding, it is a closed state. What happens with the perampanel? So this is a non-competitive antagonist of the channel. So the binding sites are different. That is why it is non-competitive. In a competitive antagonist, you have the binding site. The agonist and antagonist compete for each other. In a non-binding or non-competitive, there is a separate site for perampanel binding. So once the perampanel binds, even if there are high concentration of glutamate binds, but the channels do not open. So even if there is a high concentration of glutamate, with the presence of perampanel, the channel remains in a closed state. So the channel does not act. So the transmission does not happen. So that is the action of perampanel. In summary, glutamate is the principal excitatory neurotransmitter, and it has two receptors, AMPA and NMDA. AMPA is the main receptor for EPSP, and it is required for epileptic discharges. We all know that. Perampanel is a selective, non-competitive AMPA antagonist. So it is a novel mechanism of action, because various other medications we know work through sodium channel blockers or calcium channels or GABA mediated channels. So this perampanel, having novel mechanism of action, can be rationally combined with any other anti-seizure medication practically. So this is the first in class of this AMPA receptor antagonist, and most important properties to know about: it has a long half-life of 105 hours. If you compare all other anti-epileptic medication, this is one of the longest, and food does not interfere with its absorption, and approximately nearly 100% of them are plasma protein bound. So it has its implications for dialysis and other patients, and clearance is affected by the CYP3A4. So the enzyme inducers will have a rapid clearance, especially for our interest, oxcarbazepine, phenytoin, and carbazepine, which are potent enzyme inducers, will increase the clearance of perampanel. So we need to be mindful of this interaction very much. And clearance is of course reduced by inhibitors, but it is not very practically that important. There is interaction with progesterone containing contraceptive pills. So perampanel decreases progesterone level, so contraceptive efficacy may go down. Most important information about dosing: this is because of their long half-life, it can be used once a day at bedtime. That's more important, with or without food. We always start with a slow dose of 2 milligram per day, and every 3 or 4 weeks we titrate upwards by 2 milligram. So start with 2, go to 4, then after 3-4 weeks 6, 3-4 weeks later 8 milligram. Usual median dose is 6 to 8, but it can go up to 12 milligram. So the tablet comes in 2 milligram, 4 milligram, 6 milligram, and that is what is available in India. But abroad you have 8 milligram and 12 milligram tablets also. So to make it 10 or 8 milligram, we combine 6 milligram and 2 milligram, or 6 milligram and 4 milligram tablets. So titration is usually every 3 or 4 weeks. We increase by 2 milligram. But if the patient is already on enzyme inducers, you can titrate more fast. In terms of every 2 to 3 weeks, you can increase by 2 milligram. The advantages are: in renal impairment, mild and mild to moderate hepatic impairment, you don't have to adjust the dose of perampanel. But in a severe renal impairment or severe hepatic impairment, of course, you need a dose adjustment. And this can be combined with any anti-seizure medication. We talked about that. Coming to the safety, this has a black box warning for serious psychiatric and behavioral changes, especially suicidal and homicidal thoughts. Similar black box warning are available for lacosamide, topiramate, and levetiracetam also. So you have to be mindful of this. Sometimes patients go on Google and they come back to you with, sir, there is a serious suicidal thought, warning is given. So you need to be able to counsel the patient about that. The common side effects are dizziness, somnolence, vertigo, aggression, and anger. There may be blurred vision, irritability. So this we know most of the anti-seizure medications, especially on a higher dose, can cause all these CNS-related side effects. So there are some other interactions as well. It can increase the CNS depressant effects of acylazidine, methadone, mirtazapine, oxcarbazepine, and zolpidem. So you need to be mindful of CNS depressant effects that can be synergistic with the addition of other medications. Coming to the availability and FDA approval status, it was initially approved only for partial onset seizures back in 2012, initially in European countries, then in US, but now it is approved for both partial onset as well as generalized onset seizures in most countries. And the age group of indication slightly differs from US and European countries and India. So in US, basically for partial onset seizure, that is focal epilepsy, it can be used for monotherapy as well as for adjunctive treatment for children more than 4 years. But for GTC seizures, especially, it is used only as adjunctive treatment for seizure. In US, it is more than 4 years, but for European Union, it is used only as adjunct both in focal as well as generalized seizures only above 12 years of age. So this is the age group difference in terms of indication. In India, basically it has been approved for both indication of focal epilepsy as well as generalized epilepsy above 12 years. Recently, for focal onset epilepsy above 4 years, the official approval has come for the focal epilepsy, but not yet for generalized epilepsy. So in India, focal epilepsy more than 4 years, you can use Fycompa. Fycompa is the only medication available at the moment, only commercial preparation available, because it is still under the patent. So we don't have any other generics at the moment. So role of Perampanel in focal epilepsy. So there are many studies for post-marketing surveillance. This is one such one year observational study of multicentric 18 Spanish hospitals, more than 12 years, focal epilepsy with secondary generalized seizures. And in that you can see the first graph shows it is almost 1/3 of patients were very effective, including simple partial seizures. Nearly 60% of the patients had benefited, and the secondary generalized seizures, nearly 3/4 of the patients benefited. This is one most important finding that you should take away from this study, because many focal epilepsy with secondary generalized seizures, this can be one of the useful medication. And you can see up to 10% of patients can be completely seizure free depending on the duration, and nearly 40% of them are more than 50% seizure reduction. And as you can expect, this slide shows if you are titrating every week, your side effects can be as high as 50%. But if you are titrating every 2 or 3, 4 weeks, the side effect profile will be much less. So nearly 2/3 of patients do not have any side effects if you are titrating slowly. That is very important. And this is real life experience data for Perampanel from various European and North American countries. So you can see nearly 50 to 60% retention rate for 1 to 2 years, as well as 10 to 15% seizure freedom rate. That is very important. So this study again, one multicentral study, observational pooled data from Europe, again shows 50% retention rate as well as 1 year seizure freedom rate about 9%. So that's what you can expect. 10 to 15% of patients can become seizure free. In our experience, we have used in many patients, including less than 10-year-old children, for both focal as well as generalized epilepsy. We again have a similar experience. I have at least 3 patients that are completely seizure free on Fycompa. Those patients were already tried on almost all anti-epileptic medications before trying on Fycompa. So they are severely drug-resistant epilepsy patients. So coming to generalized epilepsy, you can expect this to be very effective. This is very important. Any drug, new medication, initially tried on focal epilepsy, then they are tried on generalized epilepsy. That's how the study data comes out. So if you see this data, you can be very surprised that most of these genetic generalized epilepsy or primary GTC seizures, it is very effective to the tune of 50%. So what is the role of add-on therapy? Till now, what we talked about is a monotherapy with Fycompa versus placebo. Then we all know first we add anti-epileptic medication, initial monotherapy, then alternative monotherapy, then we go to adjunct therapy. If there is no response, then we go to label them as drug resistant and look for other options. So if you are adding this as an early add-on, what do you mean by early add-on? First or second add-on therapy. So more than 1/3 of patients can become seizure responders, as well as nearly 10% of patients can be seizure free. Whereas if the patients have already tried on more than 2 anti-epileptic medications, the seizure response in terms of 50% seizure reduction as well as seizure freedom rates will be slightly less. So it is very intuitive. So you use the medication early on in a mild to moderate cases, they're definitely going to respond much better. In a severe cases, they have failed multiple drugs, so the response will be less. So that's what we are seeing in this data. So it can be effectively used for early add-on. This is another study again for early add-on therapy. Proportion of seizure-free patients was greater when the patient seizures were treated with Perampanel as a first or second add-on therapy. So that is one of the indications. So coming to summary, in one of these very nice review article by Trinka et al., the expert opinion says efficacy of Perampanel is similar in adults and adolescents. Bedtime once a day dosing is very preferable because it has a long half-life. Slow titration is very important to avoid side effects. Seizure control should be reassessed at the median dose of 4 milligram before you go on to titrate upwards. Dose escalation may be necessary in patients receiving enzyme inducers, especially carbamazepine, oxcarbazepine, and phenytoin. Adverse effects are many. Most important ones are dizziness, somnolence, headache, fatigue, and especially in adolescents and young adults, behavior problems, aggression, and hyperactive behavior. These are one of the most important take-home messages. With that, I conclude. Thank you once again for the invitation and kind attention.
Thank you, Dr. Lakshmi Narayan, for an excellent review of Perampanel. We are going to be using this molecule more and more in the coming years. So I think this is going to also be probably part of your evaluation. So Dr. Lakshmi Narayan has to leave for another meeting. One question I see here that's been put up: can we use Perampanel in porphyria?
I think I have to check. I don't know off my head the answer exactly for that. We need to definitely check that. Maybe I can check and message one of the other speakers faculty.
Yes. So as the talk was going on and as I saw this question, I was also trying to see whether we could get an answer. I didn't see any particular mention of porphyria as a contraindication for use for Perampanel. So anyway, in case we get better information, we'll probably let the group know. If there are any more questions regarding Perampanel, you can please type in, and we will take it up at the end of Dr. Ajay's talk. Okay, one last question maybe. Is it useful in drop attacks? Is one of the questions.
Yeah, I think one of the patients I used for drop attacks, the 3 patients I have been talking about who are seizure free after trying so many medications, that one of the 3 had drop attacks. So this is again effective medication for symptomatic generalized epilepsy as well as genetic generalized epilepsy. So drop attacks we can definitely try because what happens in these epilepsies, we are failing many anti-epileptic medications. We are looking for other options in our armamentarium. Definitely this will hold, especially if the patient is a slightly older age group, about 12 years for generalized epilepsy we can use at the moment in India. So if he is about 12 years, definitely I would use one of these medications. Zonisamide is another very good medication for drop attacks. If zonisamide fails, I'll definitely use Perampanel also.
Okay, thank you, Dr. Lakshmi Narayan. So any more questions on Perampanel, Dr. Ajay and me and Dr. Shripad will try to answer at the end of Dr. Ajay's talk. So now we will have Dr. Ajay Asrana, who's Assistant Professor of Neurology at NIMHANS, Bangalore. He will be talking about a unique pediatric epilepsy syndrome, the Landau-Kleffner syndrome. So over to you, Dr. Ajay.
Good evening, everyone. I hope I'm audible to all.
Yeah, audible. Yeah. Slides are clear.
And you can see my slides also.
Yes.
Sure. Fine. Very good evening. And at the outset, let me thank Dr. Shripad for having me here. And it is a pleasure to speak to all you residents. And I hope that I'll stoke your hunger even more to learn about my topic, which is Landau-Kleffner syndrome. I'll be dealing with the topic under the following headings. So what is Landau-Kleffner syndrome? So this are the people after which Landau-Kleffner syndrome is named after: William Landau and Frank Kleffner, who in 1957 described in very good detail 6 patients of 6 children who had epilepsy and language regression, and they laid out the entire clinical semiology as well as the type of language disturbances they had, which holds true to this day. And quite rightly, the syndrome has been named after Landau and Kleffner. So it is one of the distinct epileptic encephalopathy syndromes in children. And the classic feature, apart from the epilepsy that we all know of, is that there is a language element which is called as acquired auditory agnosia, which is associated with Landau-Kleffner syndrome, or LKS. It is also called as acquired epileptic aphasia. Some people prefer not to use an eponym, so some have called it acquired epileptic aphasia, but by and large, most people still use the term as LKS. It is a part of a spectrum of electroclinical syndrome. So when you talk in terms of pediatric epilepsy, at least, most of the syndromes are defined clinically as well as electrically. So it makes sense to differentiate them as electroclinical syndromes. So this particular electroclinical syndrome is characterized in the EEG by something we call as electrical status epilepticus in sleep, which we'll be talking more about later. But what it essentially involves is that when the patient or child sleeps, there are continuous spike and wave discharges which can be picked up on an EEG, which is akin to a status epilepticus, but only picked up on an EEG. So that is why it is called an electrical status epilepticus in sleep, or ESES. So this ESES is not very specific to Landau-Kleffner syndrome alone. It can also be seen with other syndromes like epileptic encephalopathy with CSWS, as well as atypical epilepsy with centrotemporal spikes, or BECTS, atypical BECTS. So it is felt that LKS somewhere lies along the spectrum of these disorders, and we will learn more about how these LKS is different from the other syndromes that we have spoken about. The clinical features: the age of onset typically is between 2 to 8 years. There is a male preponderance. In India, the incidence and prevalence are not exactly known, but studies from Japan have shown that it is about 1 in million in Japan, the incidence, and the prevalence is about 1 in 3 to 4 lakhs. Now, the clinical features, cardinal clinical features, can be summed up in 3 important clinical manifestations. One of the most important manifestation is the language regression. So as you can see, there are 3 circles that I've kept here. Each circle has a different size. The reason is that the most important symptom, or the most major symptom we see, is language regression, and the specific subtype we will be discussing subsequently. And also there will be behavioral disturbances, and epilepsy is associated with LKS to a lesser extent as compared to the other 2 abnormalities. So language disturbances in LKS typically start appearing in a child who has attained normal. His development, language development is essentially normal. And once the patient has, or the child has attained his language, he starts regressing. He starts losing his language. The onset may be subacute, progressive, or stepwise. And the verbal auditory agnosia is the hallmark of LKS. And it is characterized by a selective inability to recognize verbal sounds. So this is how it starts off usually, where the child stops responding to calls of the parents. So when the parent calls, the patient may not respond because there is a selective inability to hear. It's a sort of a pure word deafness, you could say, where only the ability to comprehend verbal stimuli is lost initially. However, in the initial stages, they may still respond to other non-verbal sounds, like say the ringing of a doorbell, or a honking of the car, or maybe a bird. So these things they may still recognize, but initially they specifically lose ability to respond to linguistic sort of or verbal stimuli. Later on, even this is lost. They become incapable of even recognizing simple sounds they may not be able to make a connection between an acoustic stimuli and the semantic information which is stored in their brain. So that is the essential problem that is associated with LKS. And gradually, as it worsens, it may also lead to other speech disturbances in the form of expressive speech disturbances, where not just a comprehension is lost, but also they start developing problems in expressing themselves. They may develop paraphasias, they may have perseverations, phonological errors, etc. They may even stutter and make very telegraphic sort of sentences. So all types of aphasias are actually known to occur with LKS at a very late stage. So if you see how it progresses, it starts off as verbal auditory agnosia, and then it may come up, and the non-linguistic sound agnosia may then come up, and then if expressive disorders and other aphasias may also start to develop, and at the end, the patient may become totally mute. Also, fluctuations are known to occur. The patient may have remissions and exacerbations, and so it may provide a somewhat a confusing picture about what is the exact nature and what is the exact extent of the problem. The second important cardinal symptom or the clinical manifestation is the behavioral disturbance. It is mostly seen in the form of hyperactivity, maybe personality disturbances where the patient has is always jumping around, maybe aggressive also in some cases. And in a minority of patients, depression has also been noticed. However, they are distinct from other behavioral abnormalities that we will come to later. There is, in severe cases, it may progress to a state of frank psychosis also. Now coming to the third cardinal manifestation, which is seizures, what we have to understand is that 100% of patients with Landau-Kleffner syndrome will have language abnormalities, but not all of them may have seizures, or they, even if seizures are there, they may be very infrequent seizures also. So seizures are seen in only 75% of patients with LKS, and when seizures are present, it may be either GTCS or it can be focal seizure, or even it can be atypical absences and also head drops, which are quite commonly seen. Now, one thing to notice here is that tonic seizure is not compatible with a patient having LKS or a CSW. So this is the statement given in one of the very good books, which is Paniatopoulos' clinical introduction to the epileptic syndromes, which I think we should all read. And also, seizures are mostly nocturnal in case of LKS. So this is about seizures in LKS. Now coming to what causes Landau-Kleffner syndrome, it is an unknown etiology as yet. So this comes under the rubric of idiopathic epilepsies, and we have to understand that not all idiopathic epilepsies are generalized. For example, we always think when somebody says IG, we always tend to think of idiopathic generalized epilepsies alone. However, there are also idiopathic focal epilepsies or IFEs, and Landau-Kleffner syndrome is one such idiopathic focal epilepsy. The cause, rarely there has been a familial association, about 10%. And recently there have been some mutations involving GRIN2A, GIRN2A, GRIN2A mutations, which have been associated with the spectrum of disorders. Another important thing to be noted here is that recently an immune basis for this LKS has now come up. And there have been studies which have shown that interleukin 6, the cytokine interleukin 6, has been produced in excess in many patients of LKS. And also, that may be the reason why many of them respond to some immunosuppressive therapy, as we will come to. So usually, LKS is not associated with any structural brain abnormality, and hence it's idiopathic. And very rarely, even if there is a brain abnormality, it may be in the form of a polymicrogyria or an FCD. Now, here is an important slide, which is the pathogenesis. So what causes patients to have these language abnormalities? I want you to look at the first slide. So you can see that there is a pruning that is going on. An unruly bush has been pruned to shape. So this is exactly what happens in a developing brain. It is a phase of an intense synaptogenesis, where thousands and millions of synapses are being formed. Now, it is not enough to have so many synapses. it is also important to have effective synapses. So the brain has to decide which are the synapses which are important, and it has to retain those synapses. And then it has to decide which synapses are not so important, and so maybe cut down on them to conserve whatever resources are or on offer. Now, this is akin, suppose you are in charge of developing roads, interconnected roads. So how would you decide which road to develop, which road to widen, and which road to close down, so that you can manage the movement of vehicles in a better manner? So the best way to do this would be to look at which are the roads getting the maximum amount of traffic during the day. That is exactly what the brain does. It sees which are the synapses which are most utilized during a child's daytime activities. It may be related to visual stimuli, it may be related to language stimuli. And based on that, in the night, the brain consolidates those synapses which are actively used, and then it starts pruning back or cutting down on synapses which are not used. Now, what happens in LKS? As soon as the patient goes to sleep, there is continuous spiking which goes on inside the brain. So the brain doesn't know which synapses are important and which synapses are not. So it is whatever is consolidated in the morning is lost in the night. It is akin to having a traffic jam inside the brain. All synapses are given equal importance and the brain doesn't know which one to give. So this leads to regression of milestones or language milestones which are already there, because usually the spikes in LKS are more in the temporal region. So pathogenesis is essentially due to the effect of deleterious effects of epileptic activity on synaptogenesis, and more temporal involvement is seen then it is a manifestation of Landau-Kleffner syndrome. There is another spectrum that we just spoke about, which is epilepsy with continuous spike and waves in sleep. In this particular syndrome, there is more of frontal involvement. So more of behavioral abnormalities and lesser language abnormalities are seen in epilepsy with CSWS, whereas in LKS, it is more of language and less of behavioral abnormalities. So what do the EEG in LKS patients looks like? So there is bihemispheric, and the spikes are usually posterior temporal, and it may give an appearance of being multifocal also in many patients. What happens in sleep is that there is a marked activation, particularly in non-REM sleep. And this, in most cases, occupies more than 85% of non-REM sleep or slow wave sleep. And in some cases, the threshold is set as low as 50%. So the jury is still out. Some people consider 85% and some consider as 50% of the sleep record. However, there will be an absence of normal sleep structures on EEG because of this continuous spiking which happens. And it also may give an appearance of a generalized discharge, particularly in sleep. So this is what a particular, a typical EEG would look like. So you can see here, there's continuous spikes which are going on in slow wave sleep. This is actually a slow wave sleep. You can see the amplitude maxima here. You can see mostly it is in T3, T5, and T5ON. There's a bipolar montage, so we're not looking at the amplitude maximum, but rather you're looking at the phase reversal, which is seen at the T5, which is considered as a posterior temporal. So it is seen bihemispherically and is more obvious in the posterior temporal chain. So it's a typical EEG of a Landau-Kleffner syndrome. What about the differential diagnosis? What other things should be thought? So in a clinically when a patient comes like that, it is most often confused for deafness. So the patient may be referred to an ENT physician for all you know, and he'll do an audiogram, and he may also do a brainstem auditory book responses, which turn out to be normal. And then you'll have to take a very more detailed history. And the clincher will be when you get an EEG with a sleep record, which so it is important to get a sleep record. Many times we do an EEG, sometimes the child may not sleep. And if we are not meticulous enough that we need a sleep record, you may entirely miss the diagnosis. So it's not just enough that you get an EEG, it's important that you get a sleep EEG. Another very important differential that you have to always keep in mind is autism, because autism also sometimes presents with language disturbance, and behavioral issues will be at the forefront. And it is not rare for autistic children to have seizures. They may have infrequent seizures. So there is an overlap here. Now, what helps you to differentiate is the fine print, which is what is the nature of the language disturbance. In autism, Usually it happens less than 3 years of age. So because they have only gained so much speech, it is usually seen as loss of single words. Whereas in LKS, it is at a slightly later stage of 5 to 7 years. So there is a drastic language regression which is seen. And coming to behavioral issues, usually in autism, you have a very typical behavioral issues in the social and developmental spheres, particularly in form of a restrictive, repetitive behavioral abnormalities and stereotyped behavior and very significant social interpersonal problems, which will not be there in patients with LKS. And as we discussed, it is mostly aggression and hyperactivity. So infrequent seizures, of course, in both autism and LKS. However, EEG will help you to differentiate. There is no ESES. So suppose you're in a dilemma, you're not able to really make a difference or differentiate between them. It is a very good idea in a patient with autism to get a sleep record to rule out an ESES, because the treatment, there is a definite treatment response that you could see with LKS if you treat it differently than autism. So essentially the diagnosis of LKS will hinge on these 3 factors: a childhood onset, sleep potentiated or activated generalized or spiking or sharp waves, and impairment in language development, and seizures may not be mandatory. Now, how do you treat it? Steroids are quite effective in many patients with LKS, and you should definitely give a trial of steroids. Usually given as pulse doses of IV methylprednisolone, which is given on a monthly basis at 20 milligram per kg for 5 days. So, and you could also give oral steroids, prednisolone 1 milligram per kg for about 6 months. And thereafter, you have to see whether there is a response to treatment and then decide on further management, and whether to continue with the steroids. Now, in patients who do not respond to steroids, there has been evidence that intravenous immunoglobulin may also help. The evidence is not very strong, but it is well worth trying in a patient who is affording the treatment because it is quite expensive and also is resistant to methylprednisolone. What about anti-seizure medications? So the drug of choice here would be valproate. Usually you go up to 20 to 30 milligram per kg. And then as an add-on, you could use clobazam. People have gone up to 0.5 milligram per kg, and also a nightly dose of diazepam alone have been tried, and many authors have found this to be very effective. Nightly dose of diazepam up to 1 milligram per kg. Other anti-epileptics which are quite useful are ethosuximide, especially if patient has some absences, atypical absences, levetiracetam, and even topiramate has been found to be quite effective. Now, there is another thing that you have to remember is that it is better to avoid sodium channel blockers, especially because carbamazepine has been known to worsen, and even phenytoin has been known to worsen the ESES pattern on the EEG. What about the patients who do not respond to any of these measures? Then you will have to try a ketogenic diet. Also, some surgical options, you may have to see if there is a lesion. You can try a lesionectomy. Or in some patients, they have tried a hemispherotomy also. But one of the highly recommended procedures for Landau-Kleffner syndrome is multiple subpile resections, where multiple subpile incisions are made in various parts of the brain so as to disrupt the epileptic network. What is the prognosis? The prognosis varies, and usually from a seizure point of view, they do pretty well. And about 10 to 20% of them may completely normalize as far as the language is concerned. However, in up to 50%, some permanent sequelae may remain, especially in the language domain. So persistence of CSWS, the age of onset, the earlier the age of onset, the worse is the prognosis. So these two are mainly seen as predictors of outcome. So overall, from a seizure point of view, it is not a very problematic thing to treat. From the language point of view, though the response is seen, some sequelae may remain permanently. So this is about Landau-Kleffner syndrome. I just gave you a brief overview and the must-knows about what you should know about this syndrome. I would suggest that you read this books by Paniatopoulos, which is a clinical guide to epileptic syndromes. Then you have an entire supplement in epileptic disorders, a series of articles on ESCS and the spectrum of disorders, and also this article by Stefaneto et al., which I think if you are really interested to know more about this, these are useful resources. So I thank you for your attention. I'll just end by showing this picture. This picture belongs to Penelope. So this is from the novel of Ulysses. So there is a very, some people call LKS as Penelope syndrome. The reason is that Ulysses went on a war to Troy, and he was away for 20 years. So this is his wife. So she supposedly, there are a lot of suitors who come to marry her during this time. And so she keeps them at bay, saying that she is spinning a cloth, and once she's finished spinning that cloth, she will be ready to marry anybody that comes. But she is very clever. What she does is she spins this cloth in the morning, and in the night she unweaves them and says that the cloth is not yet ready, and just to keep them at bay. So this is somewhat similar to what happens in Landau-Kleffner syndrome, where you spin in the day, but you spike in the night, and you end up losing everything that you gain during the day. So I thank you all for your kind attention. I again thank all the organizers for having me. Thank you.
Thank you, Dr. Ajay. That was a wonderful presentation on Landau-Kleffner syndrome, covering all the points that you would require for your practice and for exam purposes. So we have one question that has been put up by Dr. Pramod. He asks, do early versus late therapy affect prognosis? And when do you recommend the GRIN2A mutation or any pointers to do this mutation?
Yeah, that's a very good question. Thank you for that. Now, definitely the earlier you start treatment, the better is the prognosis. This is because the later you start the treatment, the more advanced the course and the more language regression has happened, and the more the synaptogenesis has been impaired, and not all of that may be reversible. So early recognition and early treatment is quite useful, and there have been reports which suggest that you start treatment early. The persistence of CSWS is also so much lesser, and that will definitely help in gaining back whatever milestones, language milestones that have been lost. Now, coming to the GRIN2A mutations, now this has been only recently discovered, and it has been discovered in patients who were having atypical absences and CSWS. Now, not all of them fit perfectly with the Landau-Kleffner syndrome diagnosis. The others had other atypical BCTS or the other spectrum of ESCS. Now, which one of them of these patients to take up for GRIN2A, particularly in a country like India where resources are limited, I think we don't have any clear-cut guidelines, and we don't know enough at this point of time. However, is there a therapeutic advantage in doing GRIN2A? There is a recent case report where the GRIN2A is actually, it acts via NMDA receptors. So some patients have been tried on memantine, and they have reported, it is just a case report, they've reported that the patient had complete seizure freedom and improved completely. This is not an LKS case, but this is a case of refractory seizures. So this is more of a research tool at present, and if you are able to prove that you could essentially give these medications, then the guidelines will emerge and more clarity will be there in future. So till then, I think unless the patient is quite well off and wants to know more, or himself comes with this sort of Googling and all, then only then you may do it and then hope for the best. Anything Pramod sir wants to add to this?
No, I think very well answered. I don't see any more questions. You can type in your questions and we'll probably take it up following the quiz session. So now we'll proceed with the quiz. And I think most of you are familiar with this, the protocol for the quiz. This has a poll integrated into the presentation using a Slido app. So you'll have to log in. You'll have to log into the Slido app or the Slido web page, and then I will give you a 4-digit number. that you will have to key in when they ask for it. The 4-digit number is 2936. So the 4-digit number for the quiz is 2936. And this, when you type it, you will connect to my presentation. So this is a Slido number is 2936. I'm just typing it for you people to see. So once you're ready with that, we will go through the questions. There are roughly 30 questions. Depending on the time, we'll see how much we can cover. And it basically is derived from all the 10 topics that you've attended over the last 3 sessions. So it's just a revision basically. There will be one correct answer. So just to make it easy, we've kept it as one correct answer. So I hope all of you are able to log into Slido and type in those 4 numbers, 2936. I'm just sharing my slide. It's taking a bit of time. Ajay, you've stopped sharing your slide, no?
Stopped sharing my slides, sir. Yes.
Okay, so where is it? Just...
Pramod, we are able to see your screen.
Yeah, it's loading.
Yeah, it's just loading. So in a second, we should be there. Because you're... So the tab before the tab before this Slido thing, already your epilepsy quiz fine is ready, Pramod. The tablet, the left side of the
Next, my Google slide. Okay, it's ready now.
yeah, it's all done. Great.
Okay, so you can see the number there too.
Yes.
So I think in view of want of time, we will start, and please join in as and when possible. So we'll go through some 30 questions, and so let's begin. So the first question is regarding basics of epilepsy, epileptogenesis, and neurotransmitters. So which of the following statements is false regarding neurotransmitters and epileptogenesis? So we have GABA A receptor activation causing chloride influx and hyperpolarization. GABA B receptor activation, which causes potassium influx and hyperpolarization. NMDA, AMPA, and kainate receptor activation by glutamate causes sodium influx. And NMDA receptors also act by calcium influx. So these are 4 options. I'm going to give you the polling opportunity now. So you have 15 seconds and please vote for one of these answers, which is false. Okay, so fine. So there's mixed answers here. So GABA B receptor activation causes hyperpolarization, but it causes potassium efflux. So we know that hyperpolarization is either chloride influx or potassium efflux. So here the direction of potassium current is wrong. So that is the false answer. Glutamate acts through the NMDA, AMPA, and kainate receptors, and they cause sodium influx, whereas NMDA has an additional mechanism through calcium influx as well. All right, let's go to the next question. So that was the answer. The following statements are true about epileptogenesis, except neuroinflammation plays a role in epileptogenesis. Axonal sprouting, neurogenesis, and gliosis are the chronic changes that result in epileptogenic networks. Kindling is the main mechanism at play in human epileptogenesis, and activity-dependent disinhibition results in hyperexcitability of epileptic networks and seizures. So 4 options about various factors in epileptogenesis, and here are your options and your polling time starts now. One of these statements is false. Okay, let's see the responses. Okay, good. All right, so that's good. Now, what is the correct answer? Kindling has been demonstrated in animal epilepsy models. There are some people who believe that it plays a role in human epilepsy as well, but we don't have conclusive proof. So this is not the main mechanism currently as far as we know. Now, the last statement, last option, activity-dependent disinhibition. So basically you have epileptic networks. There is an excitation-inhibition balance that is maintained. And once in a while, episodically, the balance is tilted in favor of excitation. When excitation happens, it encourages more excitation by reducing inhibition in the network. So it causes activity-dependent disinhibition. This increases the excitability even further, and this goes on increasing till it crosses a threshold and triggers a seizure. So activity-dependent disinhibition is one of the ways seizures happen. Okay, let's go to the next question. The most common localization-related epilepsy is idiopathic, cryptogenic or symptomatic epilepsy, Lennox-Gastaut syndrome, benign centrotemporal epilepsy. So among these, select one, and your time starts now. Which of these is the most common? Localization-related epilepsy, not epilepsy in general. So let's see your answers. Okay, that's benign centrotemporal epilepsy is common, but not the most common. And you should know it occurs in children in a particular age group. So we did not mention any specific age group in the question. Cryptogenic or symptomatic epilepsy is probably the largest group. And this is an interesting group because some of them are surgically remediable. And that's why we need to image all new epilepsy patients. The next question, the proposed mechanism of injury in Rasmussen's encephalitis is B cell mediated, T cell mediated, both B and T cell mediated, macrophage mediated. So what do you think? Answer, and here is your time. One correct answer. Okay, let's see the responses. Okay, so various opinions here. It's a difficult question, and let's see the answer. Very good. So that's T cell mediated. And in that also, it's a specific type of T cell, the CD8 T cells. They are recognized by the presence of certain granules called the granzyme B granules. These are considered to contain neurotoxic chemicals, and they are seen in greater abundance in the cortex of Rasmussen's encephalitis. Now, staying with Rasmussen's, this is another question. Following is true about Rasmussen's encephalitis, except age of onset is around 6 years. Epilepsia partialis continua is always present. MRI may show caudate and putamen hyperintensity. Bilateral interictal epileptiform discharges indicate cognitive decline. So which of these is not correct? I hope all of you have been able to log in and do the polling. Okay, so let's see the answer. Very good. So that is the correct answer. It's seen in a large number of patients, but not in all patients. And onset is around 6 years. And MRI changes do show caudate hyperintensity. So it is the EPC, what we say, is seen in 56 to 92%, but not in every patient. So we now a question on Landau-Kleffner. Let's see how well you followed that lecture. Which of the following is a cardinal feature of Landau-Kleffner syndrome? Aphasia, auditory agnosia, refractory epilepsy, behavioral abnormalities. Which of these is the defining feature of this syndrome? Okay, so let's see the answers. Okay, fantastic. So Dr. Ajay has done a wonderful job. You've got the answer right. It's auditory agnosia. Aphasia is seen in a good number of children and occurs later in the disease. And there are different types of aphasia, but the defining feature is auditory agnosia. And as Dr. Ajay mentioned, seizures may be present, may not be present. And behavioral abnormalities are seen, but not universal. Now coming to non-epileptic attack disorders, which of these features is most specific for non-epileptic attack disorder? Side-to-side head movements, pelvic thrusting, long duration, ictal eye closure. So here are your options and your time. All of them may appear correct. So the question is, which is most specific? So statistically, which is more specific? Okay, let's see the answers. All right, so that is not the right answer. Ictal eye closure, in terms of studies, is shown to be most specific. All others are also correct, but the specificity is lower than ictal eye closure. So this is the slide from one of the presenters. It shows high specificity for ictal eye closure, fluctuating course, opisthotonous posturing, side-to-side head movements, and ictal weeping, which was not part of your options. Now, staying with non-epileptic attack disorders, the following are considered as risk factors, except child abuse and neglect, male gender, a major accident, and previous functional disorder. So one of these is not a risk factor. So which one? Please select. Okay, so let's see if you got this right. Very good, very, very good. So that is indeed the right answer. So these are some of the risk factors: a cardiac condition that causes fainting, diabetic and other metabolic disorders, female gender, not male gender, child abuse and neglect, major accident, somatization are all risk factors for developing non-epileptic attack disorder. Now coming back to Rasmussen's encephalitis, we know it as a unilateral hemispheric disease, but it can be bilateral. And when do we say so? Is it when we see interictal epileptiform discharges on both hemispheres? When MRI shows atrophy in both hemispheres? When there is cognitive decline to suggest bilaterality? And biopsy showing evidence of histopathological changes on both the sides? Which of these is necessary to call it bilateral? Your time starts. Okay, so let's see what you got here. Very good. There are different options that have been suggested, but most of you have opted for the right answer, which is biopsy is the only way to say it is bilateral. You have to document bilateral involvement on histopathology. Right, now a different question. A 34-year-old patient has a history of new onset complex partial seizures. EEG shows right temporal slowing. CT scan is normal. What would be the next investigation? Video EEG, structural MRI, FDG PET, or ictal SPECT? Choose the options. The next proper study is what is asked. All right, so let's see what you have chosen. And I expected it to be structural MRI. Most of you have got it correct. Video EG would come in later. So for all epilepsies where there is a focal epilepsy or a localization related epilepsy, a good MRI, preferably an epilepsy protocol, is required. And if you have an underlying structural lesion, it is useful for treatment and for prognostication. Video EG would be applicable later. In MRI negative epilepsies, that's where FDG PET or ictal SPECT becomes important. The next question is, what is pharmacoresistance? Failure of any two anti-epileptic drugs, failure of two appropriate anti-epileptic drugs, failure of three anti-epileptic drugs, failure of all anti-epileptic drugs approved to treat focal epilepsy. Which of these is the right definition for pharmacoresistance? Okay, so what's the answer? Right, very good. That's an important definition to remember. So it is failure of two appropriate anti-epileptic drugs, and we should also add at a proper dose. So it can't, if the suboptimal dose, then you would not get the right response. Now, what are the predictors of pharmacoresistance? Frequent seizures, an identifiable lesional epilepsy, a poor response to the first anti-epileptic drug, or maybe all of the above. So choose your response. Predictors of pharmacoresistance. All right, so let's see the answer. And when you see all of the above, mostly that's the right answer. So it is all of the above. An MRI lesion, poor response to the first medicine, and frequent seizures would all suggest risk of pharmacoresistance in that patient. Okay, so this Dr. Lakshminarayan showed a slide. I hope you remember it. The likelihood of patients with intractable partial epilepsy becoming seizure-free when a third or additional anti-epileptic drug is added is approximately how much? Is it 4%, 20%, 40%, 60%? Here is your chance to vote on this. All right, and the answer is overwhelmingly correct. It's just 4%. So the first medicine, more than 50% respond. The second medicine, 12 to 15% respond. After that, when you try the third medicine, it's probably just 4%. Right, so now, what anti-epileptic drug would you choose initially in an adolescent girl who has an unclassified epilepsy? You don't know whether it's focal or generalized. So the options are carbamazepine, levetiracetam, lacosamide, and sodium valproate. So the main point here is adolescent girl and an unclassified epilepsy. All right, so the answer is wonderful. Very good. So that is the right answer. Carbamazepine, widely used for focal epilepsy. Lacosamide, also approved for focal epilepsy. Here we do not know what epilepsy the girl has. Sodium valproate is for generalized epilepsy, but you do not prefer it in women of reproductive age group because of higher occurrence of PCOS, menstrual irregularities, and of course, later on, risk of teratogenicity when they become pregnant. And so levetiracetam would be the best because it is approved for use in focal and generalized epilepsy and has a very good adverse effect profile. Now, patients with symptomatic epilepsy from which of the following substrates are least likely to become seizure-free with anti-epileptic drug therapy? Hippocampal sclerosis, cortical dysplasia, trauma, tumor. Which of these are more likely to be resistant? So choose your answer from these 4 options. So all of them are likely to have a higher chance of developing drug resistance, but of the lot, okay, the correct answer is hippocampal sclerosis, but focal cortical dysplasia is very close. So it's not necessarily a very wrong answer, but if you have to put it in order, hippocampal sclerosis followed by focal cortical dysplasia. Which symptom best distinguishes nocturnal complex partial seizures from nocturnal panic attacks? Can be very difficult to differentiate. So what points would help? Anxiety, autonomic activation, confusion, abrupt arousal in case of panic attacks. So which of these might help us differentiate? Very often we may be able to differentiate only with the ictal video EG recording. But as far as history is concerned, okay, so not a clear-cut choice here. The answer is confusion. Patients experiencing a panic attack, they awaken from sleep typically without confusion. Whereas if it's a complex partial seizure, confusion is more common, and it is much more prolonged if it's a temporal lobe seizure, and it can be brief with a frontal lobe seizure, and the patient may just wake up partially aroused and go back to sleep. So not that we can be very certain with this, but if you have to choose an answer, it would be confusion. In children with Landau-Kleffner syndrome, spike and wave discharges are most marked in what state of consciousness? Is it in REM sleep, wakefulness, drowsiness, and non-REM sleep? When would the EEG show the most dramatic changes? So you have your voting option now. Recollect what Dr. Ajay mentioned about EEG. All right, so have you got the right answer? Very much so. So Dr. Ajay again scores because everybody has got it right, almost everyone. It's non-REM sleep, and definitely we need a sleep EEG in all patients where we suspect the syndrome. Right, so now coming to Rasmussen's encephalitis again, what is the most effective treatment? Is it steroids, IVIG, surgery, or plasmapheresis? The most effective, you may start off with something, but here the question is the most effective therapy. Okay, so what is the answer that you've chosen? Very good. Steroids are used, IVIG can be used, but the correct answer is surgery. And the specific surgery that we do is functional hemispherotomy. This is the most definitive therapy for Rasmussen's encephalitis. But of course, we can't do it for everybody. We have to select patients correctly. So this is about myoclonic jerks. All the statements are true, except myoclonic jerk of shoulder is characteristic of myoclonic absence epilepsy. Duce syndrome is characterized by myoclonus and atonic seizures. Cannabidiol is indicated and FDA approved in Dravet syndrome, where again you can get myoclonus. Massive myoclonus occurs in progressive myoclonic epilepsy. One of these statements is wrong, so you can choose now. Okay, so what's the answer? All right, so here we have a problem. Myoclonic jerk of shoulder can be seen in a myoclonic absence epilepsy called Tassinari syndrome. Prominent myoclonic jerks of the shoulder, so that's correct. Duce syndrome is characterized by myoclonus and atonic seizures, so that is correct. And we know now that for Dravet, cannabidiol is approved by FDA. So the last option is the wrong one. You do get myoclonus in progressive myoclonic epilepsy, but the massive myoclonus that where a child almost falls, hits the ground, that is typically seen in Lennox-Gastaut syndrome. So that would be the option. Right, now coming to epilepsy surgery and corpus callosotomy, what type of seizures respond the best to corpus callosotomy and which one responds the least? So you have to here choose the one that responds the least to corpus callosotomy. Atonic seizures, tonic seizures, absent seizures, myoclonic seizures. Which has the least response to this surgery? Here are your options and the time starts now. Okay, so the answer is coming up. Very good. Okay, almost. You know for sure that atonic seizures respond and tonic seizures respond. So that is the most important reason for doing corpus callosotomy. Myoclonic seizures are the least likely to respond, and atonic and tonic seizures respond the best. You can have complete cessation of drop attacks. So up to 91% of patients may have a complete cessation. Myoclonic seizures, as we mentioned, have the least improvement. So we've completed around 20 questions. Let's see whether we can finish another 10 more. Fetal exposure to which of the following medications is most likely to be associated with decreased IQ during childhood? Carbamazepine, lamotrigine, topiramate, valproate. The question is regarding IQ in children born to mothers who were exposed to this particular medicine. So while we worry about neural tube defects and other defects, there is a concern about IQ of the child. So what answer is it? Okay, true. Sodium valproate, there are studies to show that there may be a lower IQ in children. There's also a suggested link between sodium valproate and autism. No strong evidence as yet. Okay, back to Landau-Kleffner syndrome. All the following are favored in treatment except corticosteroids, intravenous immunoglobulin, sodium valproate, and carbamazepine. Which of these is not preferred? Choose your option. Okay, so very good. So that's the right answer. Carbamazepine and other sodium channel blockers can aggravate the syndrome. So we should not use these. All the others are used. As we mentioned earlier, valproate is the drug of choice. And there is a role for immunomodulation. So corticosteroids and also IVIG in some patients can be used. Now coming to the newer anti-epileptic drugs, which of the following anti-seizure medication has a unique mechanism of action? Brivaracetam, lacosamide, perampanel, all of the above. Right? Choose. Okay, let's see your choice. We had a good diagram demonstrating the mechanism of action. You've chosen all of the above, and that's correct. So we know that brivaracetam and levetiracetam have a unique target, which is the synaptic vesicle protein 2A. Lacosamide is a sodium channel inactivator, but it selectively targets the slow sodium channels. And as we heard today, perampanel is a selective, non-competitive AMPA receptor antagonist. So all three newer mechanism of action. All right, so now coming to Lennox-Gastaut syndrome, what is the classical clinical triad of this syndrome? Is it intractable seizures, cognitive decline, slow spike and wave discharges, or falling episodes, early childhood presentation, normal development before the onset of seizures? The third option is prolonged GTCS, which is triggered by fever, cognitive skills advance and then regress, and we have SCN1A gene mutation, or onset before age 1, developmental delay, hypsarrhythmic EEG patterns. Which of these defines LGS? All of these, each of these represent a particular childhood epilepsy syndrome. Right, so what's the answer? Very good. The triad of intractable seizures, cognitive problems, and slow spike and wave. That's the typical EEG pattern. That's what we see in LGS. Then we have prolonged GTCS triggered by fever. You have cognitive skills that advance and then regress, and SCN1A mutation, that's Dravet syndrome. The second option is Duce. Then we have onset before age 1, developmental delay and hypsarrhythmia, that's West's. So option 1 was the right option. Regarding Perampanel, which of the following statements is incorrect? Slower dose titration is generally recommended. A dose reduction may be needed when patients are also receiving enzyme-inducing anti-epileptic drugs. Efficacy is similar in adults and adolescents, and bedtime dosing is preferable. One of these statements is incorrect. Which one? Vote. I'm sorry. Okay, please vote now. Okay, let's see the answers. Absolutely right. Efficacy is similar in adults and adolescents. Bedtime dosing is preferable. It has a very long half-life, so once a day dosing is adequate. It can cause adverse effects with rapid titration, so we have to do 2 weekly increase in the dose. So the second option, it's not a dose reduction that's required. You may actually have to escalate the dose because enzyme-inducing drugs can bring down the levels of Perampanel. What is the gold standard test to diagnose non-epileptic attack disorder? Is a detailed history sufficient? Should we do a longer EEG, like a 1-hour EEG? Should we do a video EEG and try to record the event? What about MRI brain combined with an EEG? So what is the right answer? Okay, so let's see your responses. Yes, history. Yes, it might help, but I don't think that's a gold standard test. A routine EEG is likely to be normal, and if you do it for a longer period, it's probably going to be the same. What we need to record is the event along with the video, and then demonstrate that there is no ictal EEG changes on the EEG. So that is the gold standard test. MRI brain is expected to be normal. Right, so coming to the next question, which of the following is not an adverse effect of Perampanel? Aggressive behavior, dizziness, weight loss, dry mouth. Which of these is not an adverse effect? Remember, Dr. Lakshminarayan mentioned a black box warning. One of them is part of this options here. So weight loss is not an adverse effect. They may actually gain weight. So that's the right answer. Dizziness very much present, and that's why you need to titrate it slowly. Rapid titration might trigger dizziness. The black box warning is regarding behavioral side effects. So aggressive behavior, suicidal ideation is part of the adverse effect profile. So we need to be careful. Also the dry mouth. Fine. So I think just 2 more questions to go. Cannabidiol is useful in which of the following epilepsies? Dravet syndrome, Lennox-Gastaut syndrome, both as option 1, Doucet syndrome, West syndrome, and refractory juvenile myoclonic epilepsy. So where is it most useful? Okay, so let's see your responses. Very good. It's definitely approved, FDA approved in Dravet syndrome, and also used in quite a number of patients with Lennox-Gastaut syndrome. So that's the right answer. We don't have any evidence in the other syndromes that are mentioned. So Dravet syndrome is the right answer. Right, now about corpus callosotomy, which of the statements is true? This is a curative epilepsy surgery. This is a palliative epilepsy surgery. This is performed only in children, and all types of seizures respond to corpus callosotomy. Which of these statements is true? Okay, so what's the answer? Yes, it is a palliative epilepsy surgery. It's just a disconnection. So the epileptic networks remain. It's just that it prevents spread to the other hemisphere. So it reduces generalized seizures like tonic seizures and atonic seizures. And as we saw last time in one of the questions, it does not help with myoclonic seizures. It is largely done in children, but can be done in adolescents. And it's definitely not a curative epilepsy surgery. Another such procedure is VNS, also a palliative procedure. Okay, I think one more, maybe the last. All are poor prognostic factors in non-epileptic attack disorders, except children, violent type of phenomenology, coexisting epilepsy, poor relationships. Which of these is not a poor prognostic factor? All right, so let's see the responses. Right, that's the right answer. In children is not a poor prognostic factor. The other 3 are. So if you have a coexisting epilepsy, that's not a good sign. And also if they have poor relationships and a very dramatic violent phenomenology also suggests a poor prognosis. Other predictors of poor outcome, so adults, not children, psychiatric comorbidities, dependent lifestyle, and poor education. Okay, I think this must be the last. Which of the following statements is true regarding epilepsy surgery in drug-resistant epilepsy? The effectiveness of epilepsy surgery has been proven in a randomized study. Early surgery improves seizure outcomes. Epilepsy surgery should be a treatment of last resort. Options 1 and 2. So this will be the last voting option now. Yes, that's the right answer. So epilepsy surgery has now been proven in randomized studies. We have some landmark studies by Samuel Weeb and also from Engel. So it is very clear now that it is an effective mode of therapy. And the earlier you do, definitely the seizure outcomes are better. it should not be a treatment of last resort. So as soon as you realize the patient is drug resistant, you do, instead of spending more years trying out another several series of medications, it is better to refer such a patient for a epilepsy surgery evaluation. Right. So this is just two graphs. On the right side, you can see the surgical group and the medical group, and you can see the percentage patients without seizures. So 38% of patients seizure-free. In the medical group, only 3%. So this is also the duration since surgery. And look at the surgery group, they remain seizure-free for a much longer time. So this just demonstrates that epilepsy surgery is really an effective way of treating epilepsy. So I would like to thank all of you for participating in this, and I hope we could revise it properly topics, and I hope you enjoyed it too. Thank you so much. Shripad sir, yes, done.
Yes, absolutely. Very, very useful session today. Superb. Actually, see, that's exactly what the purpose of today's session was in my mind. I chose a syndrome which Ajay so well handled, and a drug just to emphasize for the syndrome, just to emphasize basically what these particular syndromes are and how to, club in the cardinal features to make the diagnosis of a particular syndrome, how to diagnose it, and how to work up what are the differential diagnoses, and then what is the treatment approach, and what are the best modalities of treatment. And likewise with a drug, just we can't take all drugs, but a prototype we chose to show what are the important mechanisms, especially of the novel anti-epileptics, and that's exactly what was highlighted in some of the questions of the quiz as well. And then its drug interactions, its issues with cytochrome 450, and its role and its limitations. And likewise, in all these lectures, I think we served the purpose by showing you again diagnosis of certain epilepsies, the differentials, the important modalities of treatment, and then the basic mechanisms, which was the first lecture Dr. Krishnan addressed. And then the epilepsy surgery, most important, its workup, the role. How would you sequentially go ahead? A very simple question wherein you had to choose MRI as the most important before you choose investigations like PET and SPECT. And then again, moving on to drugs, teratogenicities, and we all only focus on the neural tube, but very important, like he brought on in one of the question, autism and cognitive impairment with Valpert. So many issues are there, and we have to all become aware and remember them. And say, for example, with Rasmussen's, you could be given an MRI and asked questions about Rasmussen's, about diagnosis, treatment, and then again, like callosotomy. So many issues are there with epilepsy. So the spectrum of all of them, we hope we brought on to make you guys aware what all you would be confronting in front of your examiners. That's what I wanted to say, really. Ajay and Pramod, you please add the points that I may have missed for the students.
Yes, sir. I think it was overall well topics, and my DNB residents also say this is the kind of preparation they would like, and the topic is very relevant to their preparation. And I think all the speakers have done a good job by ensuring that
Fantastic.
Important components of those topics and making it concise and easy for the residents to follow. And hopefully this will help all of them.
Yes, Ajay, you want to say?
Yes, sir. Again, thank you for bringing this all together. You have chosen very good topics, which are the final. This thing is not just to give a good answer paper, but also to learn how to clinically approach a case, and all the topics are very clinically relevant syndromes that you have taken up. So it will help them both to give good answers in the to face the examination, as well as when a patient is in front of you, you will not be left searching for answers. So I think that I commend you for this wonderful endeavor. Thank you, sir.
Thank you. Thank you. Mansi, Dr. Gupta wanted to say something. Yes, I welcome him. What did he want to suggest? Hello? I don't know. How do we get the people to speak up? I think he has exited. Pramod?
He's there, sir. He's there.
Yeah, how do we see the raised hand and ask people to talk?
I
Exactly.
think the host has to enable it, I think, sir.
Okay. Poor Mansik is not able to talk really. I think we'll just leave it. Yeah, Dr. Gupta is here. Dr. Gupta? Yes. And Binoy? Yes. Can you please unmute and say what you want to say?
So can you show the results, the quiz?
Yeah,
Oh.
I can
Oh,
show the
okay.
results.
Okay. And in the meantime, Dr. Gupta, what did you want to just, yes? You wanted to say something? Hello? I think he may have exited by now. So
Okay, I'm sharing the results.
yeah, great.
So this is the results.
Oh, Dhananjay.
Congratulations is to Dr. Dhananjay,
Yeah,
who got 28 out of 32.
very nice. He has scored well before as well.
Oh, is it? Okay. Oh, I think it shows only the top 5. I think we can see everybody's.
Great, very nice.
Very nicely done. Yes. 28 out of
Epilepsy is a difficult area, so you getting those many right is brilliant, really. Very nice, excellent. I think that ends our session, and I found it very useful myself. I have learned so many points from all my speakers, and I hope you all make use of all the efforts taken by our team. And I will share all those lectures in PDF format in the Dropbox and wherever you are able to pick up. Thank you, Pramod. Thank you, Ajay.
Thank you, sir.
Thank you, sir.
Thank you. Thank you all.
Thank you.
Thank you, Dr. Ajay.
Thank you, Pramod.
Thank you. Yeah. Bye. Have a good night.